we're live. Okay, good morning and welcome to this morning's meeting of Adult and Community Wellbeing Scrutiny Committee. Just to let you know, there's no fire drill planned and exit out the back doors. I'd like to welcome Councillor Wendy Bokett, Executive Councillor for Adult Care and Public Health, and also Councillor Liz Sneed, Executive Support Councillor, and also Glenn Garrard, our Executive Director of Adults and Community Wellbeing. Everyone else, I'll introduce you as we start on your item agenda. So we'll get started, and apologies please, Emily.
Thank you, Chairman. We've received apologies from Councillors Carter and Kendrick, and we also have Councillor Sear in attendance today as a replacement for Councillor Kendrick.
Excellent, thank you, and welcome, Noy. Members' interests, any members got any interest that they suddenly realise, just please speak up and let us know. On to item number 3, the minutes of the 5th of April 2023. To confirm as a correct record the minutes of the meeting of the 5th of April 2023, pages 5 to 9. Are we all in favour of the minutes? And can I have a proposer and a seconder? So Mark, yep, and seconded Noy. Thank you. Announcements. Any announcements? Glenn, have you got any announcements?
Thank you, Chair. Yes, just the one. Some members will be familiar with the new programme that the government has asked the Care Quality Commission to undertake, described as CQC Assurance, in which the Care Quality Commission visits all councils with social care responsibilities and effectively inspects them. If you think Ofsted, you'll be close. Adult social care is one of the few public services, arguably the biggest, which remains uninspected by a national body when compared to the NHS, education, children's services, hospitals and so forth. So you'll appreciate that this new development is I think, welcome in providing a stronger public narrative. It allows the public to understand what good looks like. It has to be said, though, that that programme is only just beginning. And for the first 6 months of the programme, which started on in April 2023, so just now, the CQC intend to run a few pilot sites. There are 3 pilot sites: Birmingham City Council, Nottingham City and Lincolnshire. The pilot sites were, as it were, self-identified. In other words, I volunteered with the support of the portfolio holder and the chief executive. This means that we will be visited by the Care Quality Commission Assurance team. There are 4 managers and 6 inspectors. They will be on site week commencing the 3rd of July. They will be here for the full week. Prior to that, we are required to produce an evidence chest, which has to be submitted by the 2nd of June. So 2 key phases. The first is the provision of information. The second is the on-site inspection itself. I'm using the word inspection because that is how it will feel, although the language of CQC in government is assurance. This was introduced by the government in the health and social care legislation that was brought to this committee winter 21-22. And we'll be touching on that a little bit later in the agenda, Chair. And both you and the Vice Chair, along with the portfolio holder, will be part of those on the interview list by the Care Quality Commission when they do arrive. The ratings for pilot sites are indicative. In other words, this is what we would have scored you had we done a formal assurance visit. Formal assurance starts from October this year. So they have a number of months in which to pilot the process with 3 councils, learn from that, and then move into formal assessments of councils from October. The overall results of those assurance inspections will be reported in the State of Care National Report by the Care Quality Commission, which also comes to this committee, usually October time. And I've no doubt will be used by ministers subsequently in understanding where social care sits on the national landscape. Thank you, Chair.
Thank you, Glenn. That's, well, my initial thoughts are that let's not compare it to Ofsted. We're adults and it's CQC, and that otherwise brings another set of whatever you want to think of Ofsted or however you take them, but we're not Ofsted. However, congratulations, and I think that there's 2 things for me. It shows leadership, and the fact that we volunteered to be a pilot scheme and that we are a lead on this as a pilot scheme is a credit to basically you, Glenn, and the team that sits in adults, that we are confident and good enough to actually volunteer to be one of the leaders, in fact the lead, because we're the first to be inspected, I believe. So, you know, and I think that's a real credit to the whole organisation actually. So I think that's very positive myself. So thank you, and let's enjoy the journey. So on that note, we'll move on to procurement of active recovery beds 2023-24, item number 5. So I welcome Afsana.
Oh, thank you.
And welcome, and we'll let you take it away. I'd just like to remind everybody that this item is a pre-decision scrutiny item going to the executive, so we will summarise everyone's thoughts at the end to put forward to the executive.
Thank you.
Thank you. Welcome.
Thank you, Chairman. Good morning, committee. The Executive Council is due to consider a report entitled Procurement and Active Recovery Beds for current financial year on 6th of June. The full report is attached to at Appendix A to the report submitted to Scrutiny Committee. Although we have been here a few times talking about and presenting different reports about active recovery beds, but I thought it could be a good idea if I start with a brief background to what active recovery beds are. So, Emily, if you could help me with the presentation, the PowerPoint, I would be grateful. Thank you. So, you haven't? Oh, you didn't? Okay, sorry. That's fine. So the background is that active recovery beds is a function, it's a service, like bridging service between hospital and community, is a local authority led and providing opportunities of a therapy focused program who are for patients who are leaving the hospitals. The service started, if you remember, in December 22 as a pilot. It is proposed now to continue with the service for the duration of current financial year. Initial funding for the service ended on 31st of March 2023. Additional funding was provided by Lincolnshire ICB to cover a short-term direct award for the reduced number of active recovery beds. Originally it was 60 and then it was reduced to 40. So with reduction of 20 beds, it was agreed to extend the service until 30th of June 2023, next month, and this is currently operational. The procurement will take the form of an open market tender, would commence in May 2023 and is expected to be completed within 4 to 5 weeks. The start date of the new contract would be the 1st of July 2023. Funding and performance. I thought it would be useful to share some of performance data and also the source of the funding for the active recovery bed. The cost of service is about £2.6 million and is the split 50-50 between us and ICB. The source of funding is from a Better Care Fund, and the patients are coming from health and local authority. At the time of, I do apologize, the patients are referred by hospital staff or social workers working in hospitals, and at the time I wrote the report, we had 200 completed intervention. So 200 people went through the active recovery bed service. 60% of people who had the service from active recovery bed went back home to the community with no support or a reduced package of care, which is a success. And it not only has benefit for local authority who is funding the packages of care, is also a really good, in terms of the finance, good option for health, because if you think about it, one recovery bed, active recovery bed, is costing about £900 per week. Divided by 7, it would be about 150 all about. But a hospital bed costs much more per night. So it is not only benefiting us as local authority, not benefiting residents of Lincolnshire to get a better opportunity of rehabilitation and basically that feeling I can go back to the community and continue living in my home is also beneficial benefits for a wider system. The reason for extending the contract is because we looked at occupancy and the turnover of the beds, and it showed that between 75 to 85% is occupancy rate, so it is good. Currently, we have got 40 beds available, and about between 2 to 6, depends on the flow of the patients, 2 to 6 beds available every day, empty. Yeah. Recommendation, Chair, the ask is as from the committee, is to approve to proceed through formal decision making for the joint procurement of active recovery beds with health. It is a joint procurement, but LCC commercial team is leading on it. Advise that the procurement will be started ahead of the decision being finalised, but no contract will be awarded until a decision has been made. Thank you very much for your time.
Excellent, thank you very much. So I'll open it up to the floor for questions. Councillor Mike Clark.
Thank you very much, Chairman. I was pleased to read the report, and it would seem to be proving very successful. It's a bit of a pity that we don't get that response from the media. We only seem to hear about the other side of it and the long delays. If it's such a success, and I know you said the occupancy was only about 75 to 85%, should we be not encouraging the hospital to discharge more patients, which then alleviates the pressure on them and also maximises the occupancy of what we've already booked? Thank you.
It's a setup, because it's a therapy-led service. In order to have a successful outcome for the resident, patient should have some kind of is a list of criteria. For instance, the resident should be able to follow the instructions, the therapist's instructions, the system of work, around the mobility, around the function, and also the cognitive. So unfortunately, we cannot offer it to everyone. It is a criteria. So, and we are, there's a triage system, all the referrals coming to the complex discharge center, HOPE, and then it will be screened for active recovery bed. Thank you.
Can I come back to Chairman,
Yes.
please? I noticed that we are increasing, I presume, because of the winter approach. Do you think we will be able to sustain the programme beyond the present timescale?
Well, would you like? I'm happy to link to intermediate care. You may be aware that we have completed a review of our intermediate care in Lincolnshire, and one of the outcomes is that Lincolnshire needs to focus more on the community-based services. Therefore, we will do everything in our power to, and nationally, it's a push for it. If you look at the latest report from Patricia Hewitt, is focusing on, and also Better Care Fund is all focusing on the community services. So we would like to give that option rather than a bed-based service.
Thank you very much.
Pleasure.
Okay, Glenn, do you want to come in on that?
Thank you, Chair. It is of note that the government funding through grant for discharge funding is a 2-year provision, which ends at the next general election. What follows, of course, is another matter, but it is an increasingly consistent theme that funding from national sources has a duration up to the next national elections, and this is one of them. Thank you, Chair.
Thank you. Thank you for that. I've got Karen and then Nikki. So, Councillor Lee.
Thanks, Chair. I think it's a great idea. I always did, and as you know, my concern was that why were we reducing the number of beds? And I think my first question would be, you say that there's two to six available in any single day. Is that right across the county, and how many hospitals? Because when you break that down, the number shrinks a bit, doesn't it, really? If you've only got space for 1 or 2 people to go from Lincoln County or wherever to those beds, actually that number doesn't seem that great anymore. And I understand what you're saying, because the very idea that hospitals hang on to patients who can be discharged is a complete myth. From first thing in the morning, if anyone is identified as being fit for discharge that day, they are the first person that's reviewed on a ward round. As soon as they're anything like ready, they're down to the discharge lounge to sit in there and out of a bed, and you've got someone else in that bed very, very quickly. So the idea that hospitals hang on to patients who are ready to go, it's a myth. And the idea of winter pressures, I believe, is something of a myth. We've got pressure all the time now. It's not just in the winter, and that's my only worry about this. I think they're a great idea, but I'm not convinced that cutting them down to 40 was, because 80% occupancy, that's not that many beds. I would ask the question, how many hospitals are there in the county, and how many beds does that equate to per hospital left empty? You know, because you can have a ward round and suddenly find that 2 people are ready to go home, and maybe both of those 2 can go to those beds, and maybe they can't. But I'm just a bit concerned that the 40 isn't enough across the whole of the county. So if you could answer that for me, please.
Of course, the 2 to 6 is county-wide stats.
And how many hospitals is that between? How many does that equate to per hospital per day?
All the hospitals in Lincolnshire can make a referral to active recovery bed, all of them. So shall we count this?
I'll come in here, because I think what we have to remember is that basically we had 60 beds, and when we've analysed it all the way through, the 60 beds was great for the winter pressure, and throughout the rest of the year we're going to 40, because that's in effect deemed to be the most efficient use of the beds. And I will just reiterate this. The active recovery bed service is not for all hospital discharges. The focus of the service is to support those with complex needs requiring an integrated response who can improve to enable them to live at home with a reduced package of care. Absolutely sums it up to perfection.
Thank you.
So,
Can I just ask then, with your indulgence, at what point is it deemed that winter pressures come in and that number would rise should it be necessary? Because I would argue that winter pressures are a bit of a myth and we've got those pressures all the time.
I totally agree with you that it feels like that is pressure is all around. It's not just October to January, February. I totally agree. We monitoring the stats and data jointly with ULHT and the Community Trust. We have a patient flow director who chairs the, we have patient flow meetings, and we currently have got 40 beds, but the 20 is standby. If we need, we call on them. Yeah, thank you.
thank you. Councillor Nikki Clark.
Thank you, Chair. It's just very briefly, a great report, and it's clearly value for money, and I'm really pleased to see that we're continuing with it. However, my point was just similarly around that winter pressures, they don't just start in December and end in March. So there would be, I'm assuming, hopefully, if we needed those extra beds, say we want to go back to 60 at any one time, there is the capacity to do that, and you would automatically do that. We wouldn't be discussing it. That's really what I wanted to clear up in my head.
Thank you. Yeah.
Thank you. Councillor Mark Whittington.
Thanks, Mr. Chairman. Can I just clarify the period of winter pressures? How many months of the year is that? Been my first question, because that has an impact then potentially on my subsequent questions.
Usually it starts around October to end of January, February.
So if we assume February, we're talking about 5 months a year.
Yes.
Okay, that's fine. That's fine, because what I was trying to do was to try to understand in my own mind where the figure of 2.5 million came from with the bed day rate, the block payment rate of 929, because I was struggling to get much above about £2.1 million, but I was assuming the winter pressures would only be 3 months, not 5, so that potentially would explain the gap there, because obviously I'm just trying to build these costs up from a weekly basis. In terms of occupancy, you said the occupancy is 75–80%. Is that on the 40 beds or on the 60 beds, or is that a kind of an average standard across the year, regardless of if we're in winter pressure period or not?
It's average.
It's an average.
It's an average.
It's an average.
And may I just add something else? In terms of the £2.6 million, £500,000 of £2.6 million, it's for the extended contract from end of March to end of June. Because in March, we extended the contract to end of
it's
June.
fine. No, it's fine. I've got that. Yeah, fine. Yeah, fine. Okay, it's fine.
Thank you.
Yeah, because I can see that. I can see that now. I've got various permutations here I'm looking at. In terms of, though, I always have concerns with block payments, especially when you've got under occupancy, because the danger of that is you're paying for a service potentially that you're not actually using, because if you're paying for 40 beds but only occupying 30 or 35, or even if the number then goes up to 60 and you've only got occupancy of 75–80%, you've still got a number of beds that aren't being used, despite the fact under the block payment method you're still paying for them. So I have concerns about that. So I just need a bit of surety around what happens there, because I'm actually thinking the care homes are actually going to get a really good deal out of this, actually. I understand that of the 2.5 million, it's half and half between ourselves and the ICB. So our share is coming out of the Better Care Fund, okay. But presumably on a risk basis, if we're in effect purchasing on a block basis and may not be getting full occupancy, the ICB will also be in a similar position to ourselves. In their block contract element, again, they potentially could also be paying on a block basis for beds that aren't being occupied. So just a bit of clarity around those points I think would be really useful. Thank you.
We are leading on the procurement and the commissioning of the beds. So we're using the money from Better Care Fund is basically like a joint pool budget. So whatever arrangement is, we are leading on it, and then we're charging Integrated Care Board for the funding.
Does that then introduce an element of risk to ourselves? I'm always really uneasy about block contracts.
Can I come in?
The pay in total if you've got less than 100% occupancy.
If you look at the price that's been negotiated for the active recovery beds, about 980 per week, I think that risk has been mitigated by the price we negotiated and agreed with the providers. That 15%. Yeah.
Glenn, would you like to come in on this?
Sorry.
And also, Glenn, just for 5.4, page 18, can you just confirm that that's correct as well, now you're on to financial figures?
Thank you, Chair. I'm going to ask Afsane to check out 5.4, if she doesn't mind, while I answer Councillor Whittington's point about the funding and block contracts as best as I can. So members have to remember that we were given a week's notice by the government of a discharge grant in December last year. The money had to be, as it were, used to best effect given the pressures on the system at the time. There was little science about it. It was an allocation to try and help NHS colleagues, particularly in acute settings, with the perceived pressures that were there, that were being reported in the national media. A second tranche came shortly after the Christmas holidays, but was allocated entirely to the Integrated Care Board. These grants were given for a period of 2 years. What is particularly interesting is that the government's primary expectation was that pressures on the system would reduce as a result of that investment. In Lincolnshire, over 80% of the grant allocated was used. There are systems in the country that only used 20% of the grant allocated, which is a far bigger risk because it risks the potential of being, as it were, recovered by government. Lincolnshire actually is one of the higher performers, Lincolnshire as a system, on that grant, which means that we were obliged to find opportunities to allocate that money that would make a difference to the hospital within a matter of weeks. During December, which of course is a particularly strong pinch point for us as a system. The use of block contracts guarantees provision which otherwise would not potentially be there. And the risk of not being able to identify a suitable bed was far greater than undersupply or underusage, particularly given the political pressures at the time, which was to facilitate discharge. Members ought to also be reminded that in terms of active recovery, it is far better to block out a number of beds in a unit than have them scattered throughout a number of units where the operating regime is effectively to maintain people in residential care. Active recovery requires something very different. And the research is very clear that operating regimes on active recovery are better separated from the normal establishment of a residential setting. And there's some really good research on that. It's also important to note that at regional level, Lincolnshire's use of active recovery beds, along with a number of other developments using that discharge grant, has been seen as best practice and recommended to other systems. Thank you, Chair.
Thank you. And that's what it's explained. Mark, do you want to?
Thanks, Glenn, for your for that. It's provided a lot of context, so I'm happy. Thank you very much. Thank you.
Thank you. Marianne?
Thank you very much. Apologies for being a few minutes late today. Thank you very much for this piece of work. I'm really pleased to see this coming forward. I'm heartened, I think the questioning has been very useful. I'm quite heartened to hear that there is capacity to change. So this is the 20 beds, but if more are needed, they can be brought online. And I think that's a really significant point, because it is important to try and keep up that 85 or whatever percent, hopefully 85% bed occupancy that we can manage in order to get value for money. And I think the point about the unoccupied beds was well covered also in the point about we're not paying for full occupancy effectively of a really expensive bed. You know, that we are actually, that is taken into account in the price there. So I think that is quite a good point. So I'm really encouraged, having seen this sort of system at first hand, well, second hand, it's for other people. I haven't actually experienced as a patient, but people close to me have. I have to say it is a fantastically important service for changing people's lives for the better in the long term. So really welcome this, and if more is needed, then we will need to make sure that we take that up. Thank you.
Thank you. Good. Andrew?
Yeah, thank you. I just the same thing occurred to me about the 80% occupancy, but I think it was probably best answered by Karen, what she said about when you actually translate that to number of beds, it is only a very small number of beds that's available across the whole county. 80% of 40 is obviously 8, so maybe there's a few more beds available per day than maybe 2, but it's still a very small number. So I too have been reassured about that, because we're here to scrutinise and look at things the other way round, and 80% occupancy is great. That means that there's 20% not occupied, and we just needed to satisfy ourselves that that is as low as it could be, and I think we've established that that is probably the case, so thank you.
Thank you. And I think really for myself, I think in some sense, you know, having read the paper, there is more benefits than really I think the paper doesn't quite sell it as there are great benefits, and I think we haven't necessarily conjured that up in some essence as well. The simplest way of looking at it is £500 for a hospital bed or £150 for this extra support care bed. And I think, you know, it's sometimes we sort of dance round a bit, but it's, you know, it's so essential for our services to operate in an efficient manner. And actually we're giving and the real benefit is actually the person that needs this care really does benefit from this setting and environment to, in effect, get better and to get back to home and look after themselves. And that's the key bit. Right, so just to summarise up, and thank you for all your questions, notes to the executive. Simon, I've got, so it's, we've spoken about basically, we think I'm not preempting here, I think we all sort of, let's first go to the vote that we actually support the paper. So, can I have a proposer, please? Councillor Nikki Clark, seconded.
Seconded.
Andrew. All in favour? Anyone against? Any abstentions? No, thank you. Unanimous. So, right, to the executive then. One of the key things is that we want to, in effect, drive the 80% as high as we can. I think this is actually also a grant. It was ring-fenced for this purpose, in which we have absolutely capitalised on, and it's a great pilot scheme. If we need the extra 20 beds, is the flexibility to do so if we need extra beds. And we've had reassurance on the occupancy rate, and I think really sometimes maybe a bit more, well, we haven't got it now, but I would say to the executive, just highlight the benefits, in effect, in a nutshell at the very beginning through. Other than that, brilliant. Councillor Mike Clark, And then it'll be Mike from now on, by the way.
Thank you.
Just so that those listening in know who you are.
Right. Thank you, Chairman. I think we should also stress that because of the benefits of this pilot scheme, it's imperative that the government continue it, not only in Lincolnshire, but as Glenn has said, it should be transported through all the areas of the national health. Thank you.
Okay, thank you. So, but no, it's a very good, successful pilot scheme, and actually I welcome these sort of things because actually we should be able to do more of these things, and central government should just let us find a bit more of what we call localism and local benefits. So, excellent, thank you. Right, we'll move on then to item 6, digital and technology update. Now this is an update for noting. So on this I welcome Derek Ward, Director of Public Health, and Theo Jarrett, Head of Quality and Information. So welcome both of you on this very important agenda item.
Thank you very much. I'll just say a few words by way of introduction, and I'll pass over to Theo to run through a presentation, because the point of this is really just to keep scrutiny in the loop. As you would expect, this is quite a developing area, both for the council but also the wider NHS system. And conversations are ongoing about where we overlap, where we need to connect. I had a conversation with the Chief Information Officer from the NHS yesterday in Lincolnshire, so we'll work that through. And as this develops, we'll come back to scrutiny to keep you up to speed on it. So without further ado, I'll pass over to Theo to run through the presentation, and then happy to take questions at the end.
Okay, thank you. Welcome, Theo.
Thanks, Derek. Thank you, Chair. So some members of the committee may be aware that we've been before with an update on digital initiatives in Lincolnshire and in particular in social care. I think the difference now is that at the time, maybe 2 or 3 years ago, it's very much an emerging issue. Now it's very much one that we wanted to look at mainstreaming. So this, as Derek says, it gives us a position statement. If we could just move on to the next slide. So in terms of the report that brought to the committee today, firstly, a recent County Councils Network report, which is entitled Adopting the Right Technology to Transform Social Care, really gives us an excellent framework to picture what work is going on in Lincolnshire, where it fits, why it will be helpful in both social care and preventative services, and also flag up some areas where we're perhaps not as advanced as we want to be, and flag up some good practice areas elsewhere. So what we've done with the report is use the framework of the report, which focuses on 4 main areas. And what I want to do is, with the slides and with the report, is just go through almost a statement of where we are for the committee's benefit. Secondly, is how does that fit into our plans for adult care and community wellbeing? So we have a document called the roadmap, where we want to be and how we're going to get there. So we'll just cover that. As Derek mentioned, there is a lot of work that's going on, both not only within the council, but with NHS, districts and community and voluntary sector partners. So there is that wider work that's going on. We'll touch on that in the report and in the presentation. And lastly, just want to cover something when we talked about taking something from the perhaps has been the periphery, digital and technology in social care and prevention, taking it into the mainstream. So we are looking at embarking on a pilot later on this year. It's planning is ongoing at the moment. What that pilot will be, what we hope to get from it, and how that will be enacted. Okay. So the first key message of 4 from the County Council's report is to really that we need to get the right systems and solutions in place to manage demand on not only the council but on care services across Lincolnshire. So what the County Councils Network did is they looked at good practice, what works, what has actually had an impact on managing demand, using digital and technology to manage demand, looking at where data is used from that technology to drive more targeted social care and preventative services. And also that third point there is the importance of integrating with health partners and other partners within the ICS. So firstly, just want to touch upon some of the things that we already have in place in Lincolnshire and where we're going with that. So in terms of managing demand, what we're talking about here is for those people who can either find care for themselves, arrange care, pay for care themselves, and have the ability to understand what their needs are, supporting them effectively. So members will know that we already have extensive information and advice on our LCC web pages, leaflets that are provided, but also we have a separate directory of services, Connect to Support. This is something that's not just fulfilling a Care Act requirement, but also extends further, and what we have had over recent months and years is increasing use of that by NHS partners in terms of social prescribers use it, primary care are now coming on board using Connect to Support as their listings and their source of information and advice. What we are doing as well is introducing, for those who can, self-assessment tools. So this is run ahead with something that we already have in place for financial assessments, but we wanted to move that into the mainstream by making that the default offer for financial assessments. That's going to be in the summer, in July. But moving on from that, looking at how a self-assessment could be put in place to people to understand their care needs and how those might be met by services or things that they can do themselves. So we have developed with a number of other local authorities and local people who co-produce this tool, a self-assessment tool for care needs assessment, and we're looking at the moment with Afsane and her managers around where that is best placed in our care pathway. So it's ready, it fulfills the need of what we want to get to with local people. It speaks the right language, but actually where do we need that in our care pathway? One thing that I want to touch on that unfortunately at the point of writing the report, the data and the feedback was not available, but now we have quite a wealth of information about something that we've been working on for a number of years with health colleagues, which is the shared care record. Members will be aware of this is a fundamental building block for integration across health and social care. The ability for professionals, care professionals and health professionals to see appropriate health and care information for the people that they're working with. So how that will work technology-wise, it's the ability of systems to talk to each other effectively. And if I'm a social worker within the council or within mental health services, what I would see on my own system for the council, that's Mosaic, I would see a small tab that was able to click into that would give me information about the person that I'm dealing with, about their medication, appointments that they might have, who's their key worker within health, what health support are they having at that time, and vice versa. So when health workers check, they're able to tell what care is in place, who's providing it. So some of the impact of this, there are around 400 social care users of this system a week. So that's predominantly teams that deal with community hospitals and the acute trust, but also it's spread across community teams. So that's pretty steady, and it saw a spike when we first launched the service at the end of 2021, but it's steady at the moment. What we do is we pick up feedback from social workers around what they're using the system for, and the feedback's excellent about their ability to manage the person's care effectively. So just moving on to the next slide, delivering quality care. We'll come on to this, the focus of this later with just the overview of the technology pilot, but what we're talking about here is technology has the opportunity to support care and preventative services in the right way. Where it's appropriate, we can use technology, devices that people can use around the home, telecare, which our current offer, things to remind people of what to do. We can use that to supplement our existing offer of care and support that you might describe as traditional. But we'll come on to more detail at the end of the slide deck here. The third key message is it's entitled Ensure the Right Kit Works in People's Homes. But what this boils down to is we might have the best technology in different things, best website, best devices that people can use, but there might be barriers for why people cannot use those things. It might be a physical thing, geographical, or another barrier. What we've done is, over the past 6 months, a year, developed a tool that allows us to know the risk of digital exclusion all over the county. And it's not the obvious, it's not just around where broadband is available. There are many, many other factors. Social exclusion, the people's willingness to use, people's fear of using technology, people's experiences. So that tool effectively built on what was a best in breed tool that was out there. And our public health intelligence team, along with the university, have developed that, and now that is being used across the ICS to target services more effectively. And just moving on, where we do know that people... Oh, apologies, Emily, just the slide before. Where we do know people are excluded, what are we doing to support them? And especially if we're moving forward, so not just support them with everyday things, but also support them to apply for council services online, to use devices that may be suitable to keep them healthy, independent and well in their own homes. So what we have done over the past 2 years now, we've commissioned a couple of local charities, or Links Digital and also Carers First, to provide some really specific digital support, training, provision of very low-cost devices, free data to get people online and to really keep them connected, healthy and safe, and their ability to use the technology that's going to help them. And we support them in a focused, targeted way. So the last key message is embedding the change. So one of the key messages coming through from the County Council's network is that point at which someone who needs preventative care or social care, that conversation that they have with a practitioner, might be a social worker or a care worker, is really crucial about their confidence in being able to access things online or use technologies in their own home. So really working with those practitioners to get them in a place where they're confident, aware, and able to actually point in the right direction is really crucial. So the report highlights some work that's been undertaken through our lead professional team that is talking about the strength-based approach that members may well be aware of. A key part of that is what we're calling tech first, technology first. So can that person use technology, maybe with some support that we've talked about earlier that we commission? Could they use technology to keep them healthy, safe and independent? And thinking about that in all cases where it's appropriate prior to the commissioning of say, more traditional care that in general might be more expensive both for the individual and for the council. So that programme of work is well underway, and the report details some impact of that. Just moving on quickly, how does that fit into our roadmap. So we've got three main areas in our roadmap that we're looking at the moment. Firstly, that first key message, managing demand, self-serve, self-help tools. So we've got a number of things there that we've got either in place or we're working on. The second column there, technology-enabled prevention and care. This is, we'll talk about the pilot in the next slide, but this is really where technology has been identified that it could help somebody. Then how do we get it? Does that person go and get it themselves, or can we help provide it and point them in the right direction? The third column there is working with the ICS in the care market, really very outward looking. Digital inclusion, as I've mentioned, supporting social care providers in terms of their digitisation. I think on the agenda, Glenn's going to be going through the next steps policy paper from the government that describes investment and transformation in the social care scene. So that does have sections on that of digitising social care and supporting social care providers to modernise what they do. And then the last point there, shared care records and remote monitoring, which I've touched on. So just a bit of detail on that middle column. This is an area that we're perhaps, if we look and we are fair on ourselves, we're perhaps slightly behind where we might want to be. Over the past year, we've undertaken a requirements analysis across Lincolnshire to understand what is it that we could be doing with technology to support people in their own homes and in care situations. And it's given us some really clear pointers. So what that's done is it's given us some confidence to start on a pilot to prove the concept that care in certain situations and in the right situations can help to build resilience, keep people independent and connected, and it can also reduce that pressure on providers at a lower cost. We're going to be introducing an evaluation of that so we understand it, and we take that evidence and evaluation forward into commissioning what might be a future care service that might be different from what telecare provision is at the moment, and how we commission care in the future. We're going to be focusing on some very specific cohorts that have been highlighted to us through that needs assessment work, and those will be targeted, and that's where we're going. So September this year, that's where we're intending to start the pilot, and clearly we can come back with more detail to the committee.
Thank you. I think one of the slides says about communicating how effective it is. The reality is if you make this easy and friendly for people to use, you don't actually have to communicate. That's all people want, is it has to flow. So when you hit it and you go in, whether it's your assessment or information, if it's easy to follow, it's great. I mean, very great, good detail, and I think it is definitely, without a shadow of a doubt, we've got to get the way forward. In fact, I think it's County Council's network said, adapt the right technology. How easy to say that, how difficult to pull that off, but it is actually, back to that simplicity. Just from my point, when I've just sort of gone through all of this, and I'm all for it, and it is the way, just bear in mind that apparently 1 million people have given up their broadband at home because of the cost of living crisis. And also we are in the world of adult social care where you can get to a point where actually you cannot access because you haven't got the capabilities or some other factor in. So there always has to be some mechanical backup, but that doesn't mean to say that we don't aim for 80% to be absolutely streamlined. The predictive model is actually very interesting, and I actually saw a very good predictive model which would be straight to Derek's heart at McDonald's, because they actually, being fast food, they work out exactly what's coming to get you spun round with under 2 minutes, and it works on a predictive model. Just on the predictive model though, back to a more serious note, prevention and predictive model, can we actually, in theory, looking forward, bring this into children's services, because they are the ones that are going to come through. With like obesity, 80% are coming through with it into adults. That in terms of obesity, 80% apparently had it as a child. And so if we look at the predictive model, we know that's coming. And actually, therefore, let's start to, we know what's coming from the children's into adults. And we need to work better on prevention, without a doubt. And I think just make sure it's really easy and friendly to read. Derek?
Yeah, just to come back on that, yeah, absolutely, that would be the plan longer term. What we've got to do here with the pilot is specifically look at cohorts and where technology-enabled prevention and care is going to help within older adults or working age adults that are relevant to this committee. But the wider approach that we need to take is use some of the intelligence that we're now joining up. Theo's already talked about the shared care records. There's another big programme of work where we are linking data whilst it's anonymised, to understand what the population needs are, and that will then allow us to go backwards, if you like, and target families and target children, young people. The committee will know that, for example, around children, young people and healthy weight, we've got a programme of work that we're piloting, and that will give us more intelligence. So absolutely, everything that you've just said, Chair, is part and parcel of the wider approach that we're looking at. I think one of the challenges with when people talk about digital is it's massive. Yeah. And we need to delineate the specific bits that we're doing, and that's where, as Theo said, the County Council Network publication is really helpful to give us a framework to follow through on this. There's also a massive overlap, as you would understand, with the NHS around what they term telemedicine, and we've got telecare, and ultimately the citizens of Lincolnshire don't care what it's called, they just want technology that's going to help and support.
Yeah, thank you. I think the only other thing on reference to digital, I did go on the website LHIH to sort of have a scout through that, and I think we just need to be careful on how many websites we start to run in the world of adult social care that don't conflict and cause confusion within the public. Because some really aren't what I call public facing, are they? Some are more like an internal system, and others are more what I call public facing. But there's websites all over the place now, and we just, I think, need to make sure we keep it simplified for the public. Derek?
Just to come back on that, I think you mean the Lincolnshire Health Intelligence Hub?
Yes.
So that is part of the County Council statutory responsibility around having a website that provides the Joint Strategic Needs Assessment, the JSNA, yeah. And so that's all done through the Health and Wellbeing Board, and this is where there are different things. What we've tried to do, and we used to have the Lincolnshire Research Observatory, members might remember, this is basically the updated version of that, but it is public facing, but certainly from the Joint Strategic Needs Assessment, that should be used by all of our partners, including ourselves, to inform what we do. And scrutiny members will know that any papers that go forwards will say, how is this referenced to the JSNA, because that's how we discharge our statutory function.
Right, okay, thank you. Andrew?
Yes, thank you. I've just got a question on page 27, which is to do with the digital care record systems for 33 care providers. It says care record systems. Are they all on different systems, and do the systems speak to each other? Because obviously people move from one place to another, and I can just imagine, oh, my computer not speaking to your computer. I mean, is all this being taken into account? Thank you.
Yes, so what you pointed out there is this is part of the government's digitising social care initiative, which will be featured in the next steps item. So digital social care records, what the government has done through NHS England is set out some standards of what they expect to see. So what we're talking about here is format, certain standards of what is the content of a digitised social care record system. Where there are lots of different systems, where systems meet those standards in terms of formatting, content, how it appears, how it can then be taken from one system and moved into another, such as our shared care record system. What they've done is they have approved those systems. So I think there are at the moment 9 nationally approved digitised social care record systems, different providers, but they're all interoperable. So the funding that we're talking about and the 33 care providers that have been funded and others that have been supported to buy it themselves, if they've already gone down that route, are all buying from an approved list with specific standards, so they will meet the requirements that you're talking about there. Yeah.
Thank you.
Thank you. Got Mark?
Yes, thank you, Mr. Chairman. Yeah, I think obviously that there's going to be some tremendous benefits to move towards a digital programme. I mean, I still remember, I think it was a number of years ago, I was at I can't remember if it was an LGA conference or a CIFRA finance conference, but there was a report presented that I think KPMG had done into Hackney Council in terms of this, and I think the report indicated that every time a member of the public accessed a Hackney Council office, it cost Hackney Council £14. Every time they phoned up, it was about £4. Every time they went online, it cost them about 40 pence. So obviously there's tremendous savings to be made in back office administration from transformation, which I think is a good thing, because it obviously means there's more money going to be available for frontline services. But I just want to sort of pick up on the point I think that the chairman was making about the digitally excluded, because with most of these things, and I think it came out from the Hackney report as well, it's back to the old Pareto principle of the old 80-20 rule, that for most of this stuff, it works for 80% of people. Potentially doesn't work for the rest, and they potentially will be the digitally excluded. We know that, for instance, super fast broadband in Lincolnshire has only reached, I think it's about 97-98% of the county. There still are pockets where people don't have that. And I think it's good that obviously making devices available and training people. But my concern is the very first contact when a person self-refers themselves, because at that point they won't have this technology that's going to be provided all the training. And I just want some reassurance that if they are part of the digitally excluded for whatever reason, and I think I think it was Hugo again who said 1 million people under the cost of living crisis have given up their broadband contracts. If you are one of the 20% who is digitally excluded, what mechanisms will be in place for that initial first referral going in, and that initial contact, and how long would it be before they would have once they'd refer themselves, have the technology, have the training in order to be able to access the services through it? Thanks a lot, thank you.
I think, though, I would say technically this is a pilot scheme to get the show on the road, and this is about sort of fine-tuning and making a step into the right direction and testing out actually where we want to go. I think, but what you're saying is right, that there is 20% potentially out there that will definitely never get into this zone. But at the same time, we have to make sure that the zone is there for 80%, because that reduces a lot. But at the same time, be quite conscious that we need a slick system to pick up the 20%. But that's the longer term plan. This is just the pilot scheme to really start, well, I say a pilot scheme. We started this journey a few years ago because we were one of the first actually to get the original funding to start it off. So the journey is getting better, but it's one of those, as we get better, so does technology and everything else. And like, who would have thought about talking about predictivity 20 years ago? We didn't even really know it. And now you look at it today and it's an amazing tool, but whether AI becomes and takes over, well, it'll certainly help out in adult social care in some sense. So, again, we have to watch that. But you're right, Mark, we need to just pay attention to that and be fully aware. So, any other comments on that? You good? Okay. I've got Nikki and then Sarah and Marianne.
Thank you, Chair. Just briefly, thank you for the report. It's really exciting. Glad to see it's moving forward. Looking forward to seeing more of it. I just need to put my glasses on. Hang on. Yeah, on page 26, I just want to ask about the 2 permanent and 2 temporary posts. How far on are we with those to help you with this, setting all of this up, please? How far on are we with recruitment? Thanks.
Yeah, so we've got the 2 permanent posts in place now, and the 2 temporary posts, there are adverts going out. It should be within the next two or 3 weeks. So yeah, it's moving on. There's plenty of work for them to do, but it's in hand.
Okay, thank you. Sarah?
Can I just give apologies to you over having been late? It was a combination of bad planning on my part and a delayed doctor's call. And also I will have to leave slightly early as well because I've got to be in Boston for 1:15. So, interesting, pertinent for me as well. I spent the weekend away with my parents and spent one morning trying to show Dad how to turn his alarm clock off on his phone, seeing as he'd woken the whole house up at 4:30 a.m. and didn't know how he'd actually even set it in the first place. So I think this is a mountain. This is a massive mountain. And you are up against the sheer practicalities of some people. For example, my dad, he's arthritis in his hands. So there's the whole kind of physical problems that are really difficult to kind of overcome, that make it really, really hard. There's all of that kind of emotional baggage, I think, that particular generation. So it's physical, it's psychological, and it's also then this sense of when the people are at this part of their life, at this juncture of their life, they're virtually in crisis or mid-crisis anyway. They're not in a good place anyway. So I can't help but worry that, in fact, the earlier we can get to these service users, the better. And what plans have we got to really kind of hit the ground early? I worry about places that existed in my community pre-COVID, residence groups, that kind of thing, where you had a really good amount of community infrastructure where people were going in a really safe space for them emotionally. I worry that they've not come back. And so I completely support the ideas behind it, anybody would. But it's just this case of how do we get to people early enough for it not just to be relevant in terms of their interactions with us, but also just for the benefit it could have for their wider life. Because I think in terms of one of the things that Glenn and I spoke about is isolation in elderly people, that kind of thing. So it's just how we move quicker and earlier.
Yeah, just one thing on that, because actually what in some sense you've actually hit the nail on the head on is that it's not actually always about the service user here. This is in effect, you could access this to support your parents, and actually that's how you would want to do it, and that is actually a large percentage of people that then in effect cover off the 20% that in effect aren't there. So it is beyond the service user, this concept.
It is, but it's also about those points in terms of mental health, isolation, et cetera, et cetera. You know, if we can, it's that preventative side of things and that proactive earlier support.
Yeah, I absolutely agree. I suspect that's why Glenn's asked me to lead on this, because of what we've done is we've changed it from technology-enabled care to technology-enabled prevention and care.
Yeah.
And the prevention isn't just for the council or the NHS to do. The support out there, and we will develop it through the pilot and as we go forwards, for families to support their loved ones is going to be really, really important. We've got a number of different tools like Connector Support already, and as we build that up and help families understand what they can do for themselves and their loved ones with technology in terms of prevention, that's the right thing for them to do, but it's the right thing for the system, because we're hopefully preventing or at least delaying further more intensive requirements. I think that Pareto principle argument is really important here, because if we can help 80% of the population that will benefit from that help, that frees up capacity, full stop.
Yeah, absolutely.
That capacity can then be shifted, if it is an 80-20 argument, into the 20% without costs going up. So it's about targeting the right sort of support for the people who need it. And a large proportion of people will be able to use some aspect of technology-enabled prevention and care, and there will be a proportion where it's not the right thing. But hopefully we'll have freed up capacity, and certainly the learning from other systems that's what they are starting to see, and they're investing very significant amounts of funding into this. We're sort of, I think we've gone through sort of pre-pilot stages, and we've had a number of different programs like House and things like that. Now we're into the pilot, and then it'll be about mainstreaming this service.
And how just one question, sorry, I forgot earlier, Hugo. When we look at technology, obviously, we're on a moving forward with such momentum. What are we doing in terms of future-proofing? Because the chances are it's going to be me, and it's going to be Hugo, it's going to be all of us in our mid-50s, who, when we're looking to do this, we don't have a clue either. And so, you know, how can we be fleet of foot enough to respond to those technological changes?
If I start the answer, and then Theo can supplement. Part of the pilot is to have a specialist dedicated provider whose job it is to keep up with all of the developments and where and how technology can help with prevention and care. It wouldn't be appropriate for us to expect our frontline social care staff to keep up with all of this. You know, you just can't do that. So having a specialist provider that's part of this model that frontline social care staff and NHS staff and others can then refer into, and that provider can then help the person and their family with the right sort of technology, both in terms of pointing them in the right direction, if it's appropriate, then providing and supporting and installing these sort of technologies is going to be really important, including taking them out again when they're no longer required, or updating as required. And we've got experience of that sort of thing with other services anyway. So it's a blended model. I think the key point from a staffing perspective is it's about asset base. We've understandably, especially in adult care community wellbeing, we're focusing on those people who need the most. But the social work approach is to be asset based, is to be positive, and then to think digital first as well. Those two things are going to have a real impact, I think, on practice.
Okay, thank you.
Thank you. Thank you. Marianne?
Thanks. Just a few things. We've been down the line before of spending a lot on digital stuff, and then not actually being able to be sure that people are getting more care. And you know, there's a history behind, and going back to the NHS and quite sometimes, the history about us thinking that digitals will fix things, and then still not having enough people to provide care. So I'm trying to focus, what I'd like to focus on is how this actually creates more care. I think what you're saying is that by pointing people off in different directions, by accessing the website, it will mean that they not so many people come forward, I guess, is one thing. And maybe the other one is if people use the checker. The benefits checker is quite interesting online. Something like that, a checker for this, to see whether they're going to have to pay for their care or not. And if they find they do, they're not going to go ahead. Or, you know, and so maybe that reduces our staff time. But I'm looking. I wonder if I could ask you to just focus exactly on how this enables us to provide more care for people. You know, I'm not against digital. I'm just wanting it not to be a barrier and a side issue, when actually what people want is the fundamentals. Thanks.
I think, if I may, I'd slightly change the language. I think what we should be focusing on is getting better outcomes for the people of Lincolnshire. So it's not necessarily care. It's a package of support that allows people to live the best lives they can. And indeed, with older adults and young children who've got complex care needs, it's supporting the family as well. So if you look at our carers service, for example, it's about supporting. So it's a tweak to language, but I think it's quite an important one, because there are those things that individuals can do for themselves if they've got the right signposting, if they've got the right support through connected support, for example. There are those things that families can do for their loved ones, and then we start to get into what should the council support, what should the NHS support. So there's different parts of this journey, and that's what we're going to be picking up through the pilot. The pilot is going to be on existing service users. We're looking probably at a couple of cohorts in our working age adults and a couple of cohorts in our older age adults, and the packages of technology-enabled prevention and care will be different depending on what those requirements are, and that's where really the experts are, the people themselves, their families, and obviously the frontline workers. So that we will work that up. We'll come back and probably be able to articulate where we are seeing advantages better as we go through the pilot, Councillor Overton, if that's okay.
Thank you. Glenn,
Just
do you want to
just
come
to clarify, if I might,
in?
Chairman.
Glenn just wants to come in on.
Yeah, okay, thank you.
Thank you, Chair. I will play herald to the future, if I may, with Scrutiny Committee. I think at some point next summer, you will be able to see the impact, the outcomes from the pilot. This is experimental. We will learn. Personally, I would have wished to have added more into this so that we could have invested more heavily and moved quicker. I think the cautionary note is well placed, though, because of for the reasons that Councillor Overton identifies, which is that we don't want to waste public money. We want to know what works well, and this experiment will allow the council to understand where it goes for the next 3 to 5 years, not just in terms of the business model, as Derek has indicated, but also the scale of the investment that will be needed to make a material difference to how well people can serve themselves, how well people can support themselves with their families, but also how much more we can make our communities resilient.
Thank you. Is that answered?
Yes, just to come back, thank you very much for that. That does help. And the point about the prevention and the wider support, I think, is well made, which would reduce the need for care. Can I also just ask, if I just pick up a couple of points, the CCN framework that you mentioned is part of the Local Government Association as well, though you wouldn't know that from the website. I just had a look at the document you referred to. So it is an arm of the Local Government Association, so that's quite a useful connection because it has got the wider testing, you know, from across the country, which I think is helpful. The links to the other systems, which actually Councillor Marfleet mentioned earlier, you know, that we do have other systems, and I think it's really important if we can use those. I know when we first started with highways, if we didn't use Fix My Street at the beginning, we created another system, and now we use the one that is already there. And I think it's, things like Benefits Checker, and if there's any of these systems that are already extant and useful, maybe they could be connected rather than reinventing another system alongside. Yeah, thank you.
Thank you. Thank you. I've got Mike and then Andrew.
Thank you, Chairman. Going back to the people doing their sort of self-assessments, some may not be capable, therefore somebody else will do it on their behalf. Is there anything in the system that can help us to avoid a fraud application, that someone would exaggerate a condition or a requirement? I'm just being, because it's all digital, therefore there's not a face-to-face. Is there any safety checks that safeguard the
Fraud
council?
prevention is perhaps what you're saying, I take it, i.e. can people in effect milk the system because it's online and there's no physical check? Glenn.
Thank you, Chair. So a couple of examples which hopefully reassure Councillor Clark that if that were to be the case, that we would have systems in place to, as it were, ameliorate any impact on the council's budget. The first one is to think about direct payments, which is already in place. 40% of people living at home with our support access that support through a direct payment. This is the council transferring its funding for social care to them to personally then commission their own care. Two things on that. The first is that the people who typically commission their own care spend less than when it is professionally commissioned, because they're accessing family and friends in a way that the council cannot, because the council has a higher test laid against it, because it's a public body, which tells you that actually this has the potential to cost less than if the state operates on behalf of individuals. The second is that we have an audit system in place which regularly reviews what people are spending against what it is that, as it were, we've identified as a need. And that regularly returns income back to the council because people find even more creative ways typically of utilising the public funds that are given to them to find their needs. So we do have systems in place already that are operating at scale, which easily transfer into a world in which people are self-serving against a shopping list of items which the council determines are, as it were, low value or more easily self-served. Anything that typically is of high value would ordinarily go through a normal assessment gateway with the professional being involved. So again, it's a tailored response that mitigates risk. Thank you, Chair.
Thank you. So, blue badge would be a good one, because that's a well sought after asset for a lot of people. But Andrew?
Oh yes, thank you. I find digital things very confusing myself. I just wanted you to sum up for me. If there's somebody at home who's increasingly becoming frail, what benefit is it to them, this digital technology? How is it going to change their life? Because that's really, at the end of the day, what we all want to do. And I just want to get it clear in my mind, because it does seem very confused. I'm always confused by digital things, but I can imagine if I am, so will they. So what's in it for them, really? And just, you know, how is it going to make their lives better? Thank you.
That's a really, really big question. So I'll maybe pull three things out. I think the first thing to do is, in that example, somebody who's living at home but a frailty is increasing, that's a really good example of where we need to work very closely with our NHS colleagues, because in terms of doing that, how it's good for them is what that individual won't want is a whole load of digital technology being put in by the NHS, and then a different set of digital technology potentially being suggested through adult social care. So there's something about wrapping around that individual based on their needs, understanding where technology will help to deliver those needs. So that's the first thing. An example of that might be the NHS may want to do remote monitoring of, let's say, blood pressure, to make sure blood pressure is not dropping, so that person falls. If they're frail, they're more likely to get a fractured neck or femur, end up in hospital, etc., etc. So we've got to wrap all of that together. So that's one example. Second area where I think there's a real advantage, it's not just to the individual who's frail, it's to their family. So at the moment we've got sort of telecare response. The opportunity of a response that's based on 21st century technology rather than technology from the 1890s is a really big jump, and we've already tested some of this out, sort of pre-pilot, with remote monitoring systems that family can plug in a smart plug into the kettle or the TV, and they'll get a little alert on their phone app that mum's actually put on the kettle at sort of the time that they normally do, so that I feel a bit more comfortable that she's up and about and everything's fine. Equally, they'll get an alert if mum hasn't done that in a 2 or 3 hour window. And the technology will learn what those windows are and different days. So weekends might be a bit different to weekdays, or they might not. And then that family member can check in. So it's starting to use technology, and the chair mentioned about AI, and AI built into apps to understand patterns of behaviour and support there. So I think it's a really good challenge about the individual doesn't necessarily have to understand the technology. That's where a specialist provider with frontline workers working together provide the support and care. The individual doesn't need to understand how blood pressure monitors work, but the clinicians need to know that. So we've got to work that through, I think, in Lincolnshire, especially in our more rural areas and our coastal communities, where some of this is a real challenge because it's hard to get out. So they're all potential advantages.
Yeah, I think that's what I was hoping you were going to say. My experience is there's an increasing number of frail elderly people. The family in the old days would probably live 2 doors up, and now they might live 200 miles away. And it's those sort of things which I think can be really life-changing for the families as much as the person involved. And that's what I was thinking you were meaning, and I just wanted to be sure. Thank you.
Thank you. Okay, well, that's been very useful. The only thing I would I don't know whether you've got counted, is that at the end of all of our digital, wherever you are, when you do a Teams meeting, it generally, after so long, it'll ping up and say, how do you rate it? And I think that at the end of everything that we do on this should be a rating - feedback, so that we can keep evolving to get better. It's no good us designing something and actually people don't understand it. And I think that asking for feedback in a pilot scheme is really helpful so that we evolve it. The other thing is, I would suggest that it comes back, and I'd put down a year, Glenn put next summer, but Simon, I think reality is we need to let it get going, and at least it'll want 6 to 9 months to just get going before it's worth coming back. Sarah?
On that point about it coming back, would it be possible for, as this develops and as we keep our eye on it, to actually include case studies? I'm just thinking of that very practical, knowing when the kettle's plugged in. If we can get some case studies early on, both in terms of pros and cons, people might feel it's an awful intrusion for their daughter to know that they're putting the kettle on.
Yeah.
Do you know what I mean? If we can get that sense of how it's actually, those real life case studies, I think it'd be really helpful.
So, Derek?
If scrutiny are comfortable, if we schedule for next summer, because that will get, if we're starting in September, we will need 6-9 months to get running. But if we start to get some early emerging themes, and part of the pilot is we will be commissioning an external evaluation from another body. We did the same with One New Lincolnshire Scrutiny, will remember, for our lifestyle service, and the university evaluated that. If there's some emerging themes coming out, then we'll come back sooner. Is that okay?
Yeah. Great. Okay. Thank you very much. And it's certainly going to be the way forward. It's just, as CCN says, just make sure you get the right technology. But at least we're having and getting on the march and the path. So thank you both very much for that. Okay, we'll move on to next item agenda. Now we're into central government updates, so which is the next steps to put people at the heart of care, a plan for adult social care system reform 2023 to 2024 and 24 to 2025. Glenn, are you the lead on this one?
Yes, thank you, Chair. So this paper and the next one are updates for committee that identify some key documents operating at national policy level. The first one is probably more material because it is actually national policy. And it builds on the white paper which was published by the government back in December 2021. That was reported to this committee along with 2 other white papers at the time. The Health and Social Care white paper, the Social Care Reform white paper and the Integration white paper. All 3 were described as mutually reinforcing legislation. As members will know, the political environment changed quite considerably in the following 12 months, which effectively meant only one of those 3 white papers actually managed to get onto the statute books. And that was the Health and Social Care Act, which brought into effect integrated care systems, integrated care boards, integrated care partnerships. And that is what the Hewitt Review talks to subsequently. The white paper on social care reform was also there to introduce a new system of funding for social care based upon care accounts. That was the single biggest element in that particular set of reforms. Government at the time decided that that was too expensive and has delayed that in terms of implementation until October 2025 in the next parliamentary cycle following the national elections. There were a number of other elements that were in the previous white paper that have been picked up in the Next Steps publication. Members might recall that the Minister launched the Next Steps document, and I think there was a level of surprise in government at the media response to it, which was quite critical, particularly with respect to the workforce grant that had been earlier identified in the white paper at 500 million, but in the Next Steps document had dropped down to 250. The question to the Minister was therefore, what happened to the rest? That actually is a relevant consideration for this committee in the form of future investment in workforce. It's also important to note that the Next Steps document lasts until the national elections, and what happens thereafter, of course, is a point of interest, but without any certainty. Rightly so, the Next Steps document continues a narrative that we have seen in previous correspondence from government and in policy documentation, particularly around supporting people to remain at home, prevention, and also to support high quality services. One of the first actions that this council has had to undertake is in respect to the, on the top left there of your screen, the Market Sustainability and Improvement Fund, which has a value in Lincolnshire of just under £2 million and has been exclusively invested in raising payment rates to social care providers, whether residential, domiciliary or community supported living. But it only lasts for 2 years. After that, it's very difficult for anyone to be clear what will happen next. That money has been allocated, having a level of engagement with our market colleagues who are supplying social care, and we today have had to make the response to the government on how we intend to use that funding in the next 2 years. So today I have signed off the grant condition report. It will go back to government along with 151 colleagues across the country, and we will see how therefore the government chooses to respond to that analysis when they finally got through that. It's important to pick up the point around digital, the paper we've just seen. That continues to be a priority for government, but again, the funding that was in the white paper for social care reform indicated 150 million for digital transformation. In the Next Steps document, it's 100 million. So again, the funding has been, as it were, reduced. The focus for that funding is largely shaped by shared care records with our NHS colleagues, but also with digitising social care. And the reason for that is that the government during COVID became very aware that it actually had very little data on what was happening in social care. It had a great deal of data on what was going on in the NHS, arguably too much. It had nothing, pretty much, on social care. It is seeking to correct that and also build on new outcomes frameworks which allow local systems, such as Lincolnshire, to report to government on a new set of metrics. These metrics have been regularly reported to this committee and largely remain intact. There are some changes. It's interesting to note that falls, for example, is beginning to feature quite strongly as a precursor to what happens at A&E. It's one of the key drivers for a particular population group in our community and the reason for admission. It does not always lead to good outcomes. So preventing falls is a good thing to do. It's also important to bear in mind that housing remains a priority in the next steps documentation. The government intended at the time to spend something like an additional 300 million in the white paper that has largely disappeared in the next steps document. And the government has introduced a task force chaired by a professor whose name temporarily escapes me. That task force has just been created. There are a number of colleagues on that task force, and it is due to report within 6 months to government on how to improve housing supply and funding to secure improved housing for older people. I have to say a level of disappointment at a personal level with that. One, because the funding has been cut drastically. And two, because the entire focus of government policy in Next Steps document is older people. It is the case that working age adults have more cost in social and healthcare than older people. Rehabilitation options for profoundly disabled working age adults have less effect than they do for older people. So the ability to prevent higher cost needs for working age people is much less than it is for older people. And yet the focus on housing reform is older people. I think that's a missed opportunity. But post 2025, I'm hoping that government will take on board the feedback which we've been giving, which says you've got to look at working age adults as well as older people in better providing housing. And it's been a subject of this committee's considerations over the last 5 to 7 years. And I'm very pleased that the Leader of the Council has chosen to make housing as much of a priority as the Council has in the preceding years, because every social care decision is a housing decision. So a number of changes between the white paper, which was a 10-year plan, to this Next Steps document, which is a 2-year plan with much reduced funding. And the expectation, I think, is therefore limited in terms of what it can achieve. And we will continue to work with government departments in pursuing both digital and housing, along with improvements to the workforce. I'm happy to take questions, Chair.
Excellent, thank you. So I think you summed that up really very well. Mutually enforced. I called it rebadging, but I thought, yeah, it is what you've said. It's sort of brought a lot of it together using existing wording and is in the right direction. So we'll see, but it's only 2 years. Mike?
Thank you very much, Chairman. I was querying a comment made on page 36 of the report, one of the last items. It says investing in additional support for unpaid carers. What do they think they mean by that?
Glenn.
Thank you, Chair. So there's been a consistent narrative with governments over a number of years about better support to unpaid carers, some of which in previous guises has been improvements to funding for carers allowance via the Department for Work and Pensions. That has not manifested to date. Although it is interesting and a mere point that in Scotland, the carers allowance equivalent has been raised substantially above that which is paid in England. Additional support to carers has been translated into the Better Care Fund narrative plan requirements, which we are currently developing with our integrated care partners across the system here in Lincolnshire. The Better Care Fund requires additional investment using the Better Care Fund to better support carers. The expectation is that it will increase the number of respite breaks and improve information and advice that we provide to carers to increasingly build their resilience, some of which relates to Derek's point earlier around use of digital. It's also something that we've invested in within the council. 5,000 staff employed by the county council, about 1 in 8 will be a carer. There's an economic argument for supporting carers because we know from national research that carers lose employment opportunities at a very significant rate, which of course depletes the workforce potential in the community. And if we have workforce shortages, one of the key vehicles for improving workforce supply is to better support carers. It's a virtuous circle if we get it right. So it comes in a number of guises, but we're beginning to see government policy formed through the Better Care Fund requirements now, not as a new carer strategy per se. Thank you, Chair.
Thank you very much. That's very useful information. In the report as well, over a number of pages, there's quotes about how much money is going to be given out. And I remember a conversation you had with us before saying these are marvellous figures, but how much does actually Lincoln get out of all this pot of money? Or are we going to be very fortunate and receive all these large sums of money?
Thank you, Chair. The only funding source that we are clear on at the moment, actually there's two. One is the Disabled Facilities Grant, which comes through the Better Care Fund. And last week we received notification from government on the scale of the Better Care Fund Disabled Facilities Grant. Today I've written to all district council chief executives to advise them of what their DFG allocation is for 23-24 as part of the Better Care Fund. That has grown as per the government's intentions as detailed in the Next Steps document. The other area has been the market sustainability funding, which is by far the biggest. And again, that is a separate element within the Next Steps funding arrangements. And today I've signed off the report that will go back to government, which indicates how we will spend that in the county council area. Those are the only two pots that at the moment we're clear on. I suspect the minister is holding back on funding any others. One of the views that both I and my colleagues have nationally is that some of the funding that was held back, first announced in the white paper, was used to help fund the discharge grant that came out in December to help acute pressures. And it wouldn't be the first time over the last 11 years where government has identified a pressure in acute systems and used funding from elsewhere to help bolster what otherwise would have been significant pressures building up in the hospitals. Thank you, Chair.
Thank you.
Thank you very much.
And just following on from your funding, in essence, the areas, so we have the digital transformation in adult social care. This is in the executive summary, which we've in effect just dealt with on the first topic, and driving innovation and improvements. Have we got other projects that in effect we can tee up? Because it sounds like there's going to be funding available for specific pilot schemes that match some of the executive in this executive summary. Are we getting in a position, and I know digital we're perhaps potentially there, but like innovation and other things, are we sort of have like a ready to go scheme if we can get the funding?
Thank you, Chair. I'm in the very fortunate position of being able to invest in proof of concept and have been for a number of years here. Members have been receiving reports on those areas over a number of years. Innovation and improvement is an interesting set of words. The first thing to reassure members about is that none of the funding identified, other than the Disabled Facilities Grant and the Market Sustainability and Improvement Fund, feature in our future projections on funding. So they are nowhere in the in the medium-term financial plan. So anything that comes to us as a result of this funding is additional. Innovation and improvement. So think delegation of tasks from health workers to social care workers. Things like diabetes injections for type 2. Classic opportunity to delegate a health task to a social care worker. Intravenous is also another area of activity where we are already piloting the delegation of health tasks, largely because there aren't enough community nurses out there to do it, to social care workers who are already visiting people who otherwise would have a healthcare worker visiting as well, and undertaking relatively straightforward clinical tasks that can be done under supervision and training. We're already piloting that, and there is significant government interest in what's happening in Lincolnshire because we tend to have a very pragmatic approach here. Some systems are very particular about who can undertake certain roles. Because of the nature of Lincolnshire, we tend to be a little more pragmatic. So we've explored some of those areas already. Delegation of tasks runs alongside new approaches to use of digital technology, new approaches to housing, all of which we are developing and investing in as proof of concepts already. This government funding, if some of it were to come to Lincolnshire, would be additional to what we're already doing. So it allows us to build out. And my personal view is that at some point next year, the council will be able to potentially make use of additional funding for digital as new models develop, building on the research which Derek and colleagues will be leading on over the next 12 to 18 months. One of the other new innovations, and it's referred to in the next steps document, is investment in international recruitment. The government 2 months ago announced £15 million to be invested in 9 regions of the country. 1.5 million of which has come to the East Midlands. And I was fortunate enough to work with the Minister on how that funding should be used and where it should go. Because there was a view that it should go to social care providers. Well, there's over 12,000. Yeah, that's a recipe for disaster. The 9 ADAS regions give a vehicle for monitoring progress, but also learning from experience. It's a programme for 2 years, last year and this year. Bear in mind, the money came out in February and it was for 22-23, as well as the 1.2 million for 23-24. So the Minister was minded to agree the recommendations, which was to fund regions to develop schemes to target international communities to boost the social care workforce, and was supportive of the idea, which was, okay, we already have Ukrainian guests. There's 1,100 in Lincolnshire, many of whom will settle here and not go back to Ukraine, because they can be here for 3 years. Okay, well, why aren't we looking at those people who want to earn a living wage? They're working age adults. Many have lots and lots of skills. That's a target community. They're already here. Their visa allows them to work in England and stay. It's a better visa system than an economic migrant would have to apply for. It's more generous. So that's target population number one. The second target population are international students already here doing masters or PhDs who need to work here who need to be resident here for 5 years to get residential rights. So they are prepared to work in all sorts of sectors, and we already have over 100 mature students from across the globe in Lincolnshire working in care who are either finishing or who have finished their master's or PhD or degree and are working in that care sector, adding substantially to our workforce operating in social care. That's target population number two. What can we do to help them? So it might be learning to drive in this country. It might be finding accommodation. The third target population are people who are internationals, not yet here, but who want to come here. The Home Office has 64,000 applications from overseas, people who want to come and work in this country. And that process takes time, but when they're here, we need to make sure of a number of things. One, that the logistics support them to have a good experience, not be brought in and then find themselves the victims of modern day slavery. Unfortunately, that does happen. So ethical recruitment and retention are key targets for the use of that funding. All providers in the East Midlands region are subscribed to this process. I'm continuing to lead the programme, and we will report to ministers probably at the back end of this year with the learning from that. I think it's a particularly exciting element of new models and new approaches.
Interesting that you get on to those that are doing masters, because all the news is about all those doing masters, and I think there's about 350,000, and then you've got their co-dependents. Do they get visas or not? Get work permits, etc. And it's all the sort of currently in the news. My only thing with this international is that, in a sense, if we don't watch it, we focus going after international and actually don't necessarily focus on developing within our own communities. And of all the things, actually, of the executive summary, it shows how we are aligned, and you've even got the CQC bit in there. But I think when you hear the government talk, and we talk about agriculture, and we are in agricultural country, they're like, actually, we should, the one thing they've been saying 2 weeks ago, we should develop people to work in the fields and pick the fruit ourselves. That's all well and good, apart from actually most of the people that perhaps want the jobs are often miles from where they need to be in the countryside to do such a job. Here you've just mentioned, in effect, that we're going for international, which is great. But in some sense, we should always look to actually bringing those round in our own schools to highlight the career opportunities within the care sector. And I don't think there's enough done of that, but it's also nice to see that they're recognising the skills for carers in care and actually want to drive that agenda, which will actually help bring people into the industry. And I think the one area, speaking to my kids' friends that have jumped into care and other people that have gone into care, they don't actually, at school, they are not shown the career pathways that can be gained out of starting. You know, you can start as a carer and end up in Glenn's position. And that's a career pathway. you can end up in various positions throughout the whole career of carers. You know, they need cooks in residential homes. You know, the world is very diverse, and it really is never, the real true pathway, I don't think, is really projected to kids enough. Glenn.
Thank you, Chair. Just a few observations. The first one is absolutely the primary focus is on our, as it were, homegrown workforce. We continue to benefit from a Grow Your Own programme that started 9 years ago, where we train 14 assistant grades to become professionally qualified in social work or nursing or occupational therapy. That also supports our turnover within the council and is a major help in recruitment. Colleagues and I spend time with our university talking to second and third year undergraduates, come to the council, whether it's in criminology, psychology, social care, healthcare, allied professions. That's also a work in progress and will continue. In addition, of course, we have the Care College here in Lincoln, which we support, and that also allows for people coming out of school with no clarity of future, and apprenticeships, which we are the highest user in the council. So absolutely, it's a blended approach. Career pathway is an interesting point because we are in discussion with our NHS colleagues about how we could have a career pathway that would recognise a health and care worker operating above a normal domiciliary care worker, for example. Nursing associate comes to mind, who can undertake some nursing tasks and is qualified to do so. That tends to operate mostly in residential settings. We're looking to expand it into domiciliary care, which again there's a lot of natural interest in. And then finally, members might recall Carolyn Nice, who was an assistant director here a number of years ago. Carolyn was a care worker in a residential home and has recently been appointed to a director post in Stockton, which I'm delighted about.
Which is exactly the sort of case of highlighting, isn't it? That you can go in all directions. The only one other thing on international care is language barriers. And it's all very well, but some people come over here and the English is actually not very good, and it's really a struggle. And actually, I know with my dog and a vet, the vet was foreign, and actually what a mess we got into, because actually what he said I took completely differently to what he meant, and it just because of that language barrier. And it's surprising how you, as an English person, we use languages and acronyms and things that actually no one else understands in the world. But there we are. Right, Karen. And
Thank
then
you,
Mark.
Chair. Where do I start? Glenn, I can hear your frustration as someone who's a very able officer sitting at looking at what, I'm sorry, is a complete mess, and thinking you could think of all these ways to put it right, but no one's doing it. It must be so frustrating. I was going to take this apart, but do you know what? There's no point, because you could just sum it up. There's inadequate funding, there's inadequate detail, there's a lot of really good aims, but there's nothing about how it's going to be done, especially not with inadequate funding. And there's complete uncertainty about the future. I mean, this is 2 years away. They're expecting to lose the general election already, aren't they? So, you know, dump it on the next lot. That's exactly how it comes across. And I think when you put it in the context of the huge amount of waste during COVID, all that money that was wasted on the track and trace that didn't work, wasted on PPE that none of us could use, contracts that were never tendered, at some point all those chickens have to come home to roost, and not having any money left to pay for things is exactly that. You talked about delegation. I agree with some of what you say, but you have to be careful, because insulin is a very dangerous drug if you overdose someone. So really, let's train these people properly. And IVs, I would never delegate IVs. There's too many things that could go wrong in terms of the right doses, things being properly prepared in the clean and aseptic techniques and stuff. I don't think it's something for delegation. You talked about nursing associates. I work with nursing associates at work. They're band 4s and I'm a band 5. They get paid less to do the same job as me, and I think it's totally unfair, and it's just another rip-off of people. You talked about international recruitment. The hospital runs very largely on international recruitment. There's a lot of Indian nurses, and I take my hat off to them 100%, I really do. They've come to a different country. Their English is good, it's very good, and their nursing skills are good. They've got a strong work ethic, and we are very, very lucky to have them. Do not for a minute think that we're doing them a favour. We're really lucky to have them. And if we get those in social care, if they do the same sort of jobs as they've done in healthcare, then I think we will do well to have done that. So I'm sorry, but I just, as I say, I could have taken this apart, but there's no point because it's nothing. It's just, and I can feel your frustration. And I don't think there's anything more to say on this, really. Let's wait and see when we make a fresh start. Thank you.
Just on that, I get your frustration, because my view when I read it originally, it's like trying to put a Porsche badge on a British Leyland car. You know, you can't make it go any quicker or do anything more. But actually, I think, and this is why I come back to Glenn's original words, mutually enforcement. It's about, actually, this is not new, but what it's actually saying is focus in these areas in the next 2 years. This is, and we're doing it, and what it's saying is just make it and bring it together to home. I actually think it's a solution for 2 years till we get to the election, and it's just reinforcing what we're already doing in some sense. But you have to remember there are some councils that are nowhere near at the level that we are at. So in some sense, we are quite ahead of the game, you know, when we talk about sort of the funding and our pooled budgets and all of that. So, yeah, I get your frustration, but I do think it's all about this sort of enforcing exactly what's out there. And I think that word summed it up well. Mark, oh, sorry. Mark, you want to come back?
Yeah, and I get your point. We're the council and we're not the government, and we can only work with what we've got. But there are people in hospitals and in social care for the next 2 years who have got this mess, you know. And at this meeting, I want to speak out publicly against that, because it's wrong. It's really wrong what we're having to deal with.
Yeah. Mark?
Yeah, thanks, Mr. Chairman. I'm encouraged when I read the report to see that an awful lot of the stuff that is in the plan we are already doing, and I think in a lot of cases doing really well. And I can on that basis see potentially why Glenn has put us forward to be one of the 3 authorities to have the CQC come in, because I do think we do things really, really well here. But for me, you know, okay, I take the point. This is probably a short-term plan to get through the next couple of years. But what really does worry me, and I know Glenn referred to it in his presentation, for me, the real elephant in the room is the adult social care financial reforms that are coming down the line. I mean that's pretty fundamental. And yes, these short-term projects and things, yes, we'll get grants and things for them, which is great and fantastic. But my real concern is what the big impact of those adult social care reforms are going to be. I mean, it seems as if there's a little bit of can kicking going on here, and my real concern is when they come in, what the financial burden's going to be, what the system's burden's going to be. I mean, we should be, because of where we are now, more able than most to weather the storm, and I really do sympathise with those areas that won't be able to weather the storm quite as well as us. But there comes a point when you've got the most stable vessel in the world, if you take it into a force 10 hurricane, you're going to have problems. So it's just a comment, really. Great that we're doing a lot of this stuff, but for me, it's that hurricane that's over the horizon that's waiting for us. Thanks.
Thank you. And The one thing though you talked about the sort of reform of financial and everything else, but you know what, that might get kicked down the road again in the next session, so we'll not get further bogged into that. But reality is somebody's going to have to sort it all out at some point in time. Right, on that, I think that's been a good debate, so we'll go into the next one, which is the Hewitt's Review, an independent review of integrated care systems. Glenn.
Thank you, Chair. So Patricia Hewitt, some members may recall, was a previous Secretary of State for Health when it was the DH, and she was asked by the Minister to undertake a review 1 year on of integrated care systems, and in particular the health and social care legislation. The review is yet to be, no, I'll start again. It is yet unclear what the government intends to do with the review, and it is possible that it will take some considerable time yet before coming to a view. There's a number of elements in here that are of interest to members, but again, this is not national policy, and we will have to wait on what the government chooses to say about a number of recommendations that Patricia Hewitt made. She made 36 recommendations. Some of those, I think, are easier for government to consider and are already arguably in train, particularly around building up from places. So if you think system, Lincolnshire is a system. Subsidiarity asks the question of, so what are our places? How many places do we have? Is it the 7 districts? Is it the 14 primary care networks? And of course, depending upon which subject matter you're talking about, the number of places could be quite different. If it's housing, it's probably going to be based around the districts because they have primary legislative responsibilities in housing. If it's children's services, it's probably not the primary care networks. If it's adult social care, particularly older people, it probably is. So in Lincolnshire, as with all other systems, the question of subsidiarity is a really powerful one and yet to be determined. How much delegation do we have in Lincolnshire in better serving communities locally, recognising that the communities of Lincolnshire are so very different? Derek's annual DPH report gives voice to that, along with how better to meet inequalities across the council area is often through delegating resources and services to those areas most in need of further support. The other areas that are probably more challenging for government, specifically the 1% additional spend from the NHS budget on prevention, that has been tried before. And what do we mean by prevention? That is clearly going to be a challenge for an NHS under significant pressure to spend over a number of years, I think it was 5 years, 1% more on prevention. Unfortunately, it ignores the fact that it is councils who do the vast majority of preventative activity. Not just counties, but districts as well. If you think about housing, finances, and leisure. These are preventative elements in scope. And it's unfortunate in a way that the integration white paper that I referred to earlier never found its place on the statute books. And that is because the health and social care legislation, and I think I mentioned it at the time when I presented that to members, talked to the NHS. It said to the NHS, come together more, operate more as one system, in local systems, and find common purpose with your local councils and your other partners. The integration white paper, which has frankly been ignored now and doesn't have any place anywhere, talked to councils. And that never happened. That was the part of mutually reinforcing that previous government narratives talked about. And that's unfortunate. But it is good that Councillor Patricia Hewitt has reinforced that message, which is local councils need to have an equal place at the table, along with social care providers, along with third sector colleagues. In Lincolnshire, that's critical. There are over 5,000 voluntary organisations in Lincolnshire. They are beginning to form a strategic narrative that can influence ourselves, our NHS colleagues. But also they can operate really locally and arguably at times have more credibility than either the NHS or the council in providing support to people, particularly hard to reach groups. The other thing that I think the government will find difficult in the Hewitt review is the argument about greater levels of local autonomy. And I know from many years with this committee, many times members have asked for or sought additional local flexibilities, which, particularly in the NHS, has not been forthcoming to date. That would allow local systems to make local decisions about delegated resources that better meet their local population needs. The Hewitt review talks eloquently to that, and again is something that is asked of government to find a vehicle which delegates out more to local systems, to Lincolnshire, more power, more ability to shift money around to better meet local needs, as opposed to operating against a national template that isn't perhaps sophisticated enough to recognise the distinctions between Lincolnshire and places like Derby City or Stockport. Again, this sits with ministers, is yet to be responded to by ministers, but I think represents an opportunity for further improvements to how integrated care systems could work if they were given more freedoms, more opportunity to invest upstream, which of course touches very much Derek's area, but also allows us to be more in the self-determining mode as a system level than we otherwise would be in the current guise. Thank you, Chair. Happy to take questions.
Thank you. I mean, actually, to be fair to her, she's done a very good report. And it raises some, which is what it should do, is raise some debate about the way forward. For me, 1% increase in prevention is just nowhere near enough. It needs to, prevention is the answer to a lot of the issues within the healthcare, is my view. When you see people sort of walking in and out. Now, some people don't have a choice, and I will say that. Some people, genetically, whatever, don't have a choice, but there are plenty that have a choice to actually become healthier and not reliant on everything. And as you say, I think really local autonomy is the one thing that drives me mad. We sit ruled by a few people in London, and we've got great people here in Lincolnshire that in effect should be given more chance in local autonomy to actually develop pilot schemes to highlight and showcase, like we're doing, that others can benefit from. But we'll see what happens. Derek wants to come in, then anyone else? Derek?
Just to add to the debate around prevention, I think important to recognise that from an NHS perspective, and this is coming out of the Chief Medical Officer as well, it's not just stopping people getting sick in the first place, it's also the secondary prevention stuff. So people with an existing condition, are they getting the right support to make sure that condition doesn't get worse, or that they don't get other knock-on impacts of a poorly managed condition? So if you've got heart disease, for example, are you getting the best care in your own home so you don't have a spike in your blood pressure that ends up with a hospital admission, that sort of stuff. And technology is another opportunity there. We talked earlier about frailty, that's also falls within the prevention argument, and I think is the more likely push over the next couple of years given the conversation we've just had around the NHS, than that wider prevention stuff that we would understand around housing and more people having access to green space, physical activity, that side of it. I don't think necessarily that's a bad thing. There is a big opportunity within the NHS to focus better on secondary prevention, tertiary prevention, earlier diagnosis. We've got real problems with our screening programs, as I'm sure you'll all be aware. So it would be a really important focus, and it's one that we're talking about with our both the Integrated Care Board as the commissioner and the holder of the budgets, but also the provider collaboratives, as Glenn was talking about, including the primary care networks. Yeah.
Okay. Excellent. Mark?
Yeah, thanks, Chair. Yeah, thanks for the report. I think it was a very good summary of the first year of ICSs. I just want to pick up on one of the executive recommendations on page 50, which talks about Patricia Hewitt is recommending the work we're undertaking to design a new GP contract, which I think is pretty important because lots of people report issues with accessing GPs and whatever for a whole variety of reasons. But I'm just wondering what Glenn's views are on that, and also potentially how, both from a preventative perspective and also from an adult social care perspective, how we could potentially, if there's going to be a new GP contract, how we could work with GPs, because I'm guessing that if they're going to be referring people, it's almost as if should they be able to refer directly into us. So just some comments on that, I think. Thanks.
Okay, Glenn?
Thank you, Chair. I ought to declare a conflict of interest, I suppose, given that some of my family income comes from a GP. Sorry. Having said that, it is an interesting recommendation, and we have to bear in mind that an increasing proportion of GPs are salaried and are paid for by the local primary care network, in effect, as a gateway for primary care services. The majority still remain to be as partners, i.e. they are, as it were, within the practice, and they are on a profit share basis. That tends to drive behaviour of GPs, and clear indication for me of where it doesn't always work. So when I worked in Liverpool, government funding for general practice in part was shaped by the need to provide a number of injections for young people who might be at risk of a certain condition. Every GP in the country was therefore paid a proportion of their income as a partnership to achieve a rate of inoculation. I think it was 80%. The level of need for that particular injection in Liverpool was less than 1/20th that of other parts of the country. In other words, it was a waste of money because it wasn't a problem in Liverpool, but it was a problem in other parts of the country. And that's one of the issues that I know Patricia Hewitt has referred to, which is that the way in which GPs are funded drives their behaviour and their points of focus. But that isn't always what the local population needs, and that's the challenge. It's also, if we did get that level of delegation for GP payments, it would also chime better with the potential benefits of population health management, because population health management allows us to better understand what community needs there are and target behaviour accordingly. When you bear in mind that some 90% of all NHS activity is undertaken in primary care settings, you very quickly realise that being able to influence that is a far bigger opportunity than anything that might go on in hospitals, which frankly is marginal gain. Now, I know that it isn't either or you'd want to do both, but it is quite clearly the case that local systems' ability to influence what GPs do is a key driver in better addressing some of the inequalities that we find and targeting resources better.
Okay, thank you. Nikki?
Thank you, Chair. Yeah, Glenn, I also just wanted to pick up on, I know they're recommendations, but I just need a bit of expansion around them. And on page 56, it mentions about establishing citizen health accounts and a health and wellbeing care assembly. And then point 17 on page 60, I actually found the word cut, which sort of gave me the shivers a bit actually when I was reading it, but the word cut is on point 17 about consideration should be given to the balance between national, regional and system resources with a larger shift of resource towards systems. I know we've been discussing that in depth today, and the required 10% cut in the RCA for 2025 and 26 financial year should be reconsidered before budget 24. Can you just explain that to me? What exactly does that mean? Thank you.
Thank you, Chair. Some of those questions might well be asked of our Integrated Care Partnership Board as well. But I can try my very best with some of this. A number of years ago, under the stewardship of Simon Stevens, the then Chief Exec of NHS England, personal healthcare budgets were promulgated, which attracted ministerial attention, and there was considerable ambition for, I think, over 250,000 people receiving healthcare to receive that in the form of a care account, a personal healthcare budget. Prior to COVID, that never actually got off the ground. Simon Stevens left, new ministers, and COVID. The consequence of which is that personal health budgets has not really resonated in the NHS. If you think direct payments in social care, personal health budgets in healthcare. Now, this is particularly good for certain groups of people with certain conditions. Think multiple sclerosis, but other long-term conditions as well. And there were a number of pilot sites back in 2015-16, which looked at the benefits of delegating out personal health budgets to people. And some of the early findings suggested that people were very creative about how their healthcare needs were met, sometimes less expensively, but very, very rarely more expensively. Because again, they were able to access other forms of support that a nurse or a GP weren't going to be able to. The assembly is an interesting point. The NHS already has an assembly. The NHS assembly was set up 6-7 years ago in 2018 and has some 60 people drawn from across the population to represent different perspectives and acts as a sounding board for national policy in the NHS. Patricia Hewitt is looking at a comparative assembly to provide something similar for integrated care systems. Because it is seen as a useful vehicle for getting early contributions from a wide range of people in society to refine what otherwise might be a blunt national policy. In terms of the cut, I think what effectively is being asked for there is that ministers have identified a number of areas for reducing spend, and the expectation is that money will be cut from some budgets. My early understanding of the Hewitt review was that continuing healthcare cuts were one that she was particularly concerned about, where local NHS colleagues, ICBs, are expected to make savings against continuing healthcare budgets, despite the fact that demand against continuing healthcare is growing substantially as a result of population and medical changes. Thank you, Chair.
Excellent, thank you. So, right, well, I think that's been a good sort of last couple of items on the agenda, just to sort of give a sort of a thought for where the government's going for the next 2 years, and then after that we'll see. So on that note, we'll move on to the work programme, just as Simon's gone out the room. So basically, as you will see, I think, where's he got? Well, since the agenda was issued, there's been 2 additions to the work programme: Lincolnshire Safeguarding Adults Board Prevention Strategy, the 28th of June, and the recommissioning of the Lincolnshire Wellbeing Service on the 29th of November. Just looking to see, that's basically it. So, right, on that note, unless Simon comes back with anything else that I might have missed, here you are, Simon. I think we've done most of it. I've put the 2
Apologies,
items.
Chairman. Did you actually mention that there may also be an item added to the September on the outcomes of the Care Quality Commission Assurance Programme?
Right, no, I'll let you say that then.
Thank you. Apologies.
Okay, no worries. So, thank you for that.
Mr. Chairman, could I just say, I know it's really hard, but this was a really long agenda today, and we often have long agendas, and I know Simon does his best to try and spread things through the year, but it is really important, I think, that we try our hardest to do that, because by the time you get to item 11, you can be flagging a bit. People have to go. We've lost people already today. Yeah. So I know we all do our best, but it is really important to spread things out as much as we can.
Just on that note, if you actually, we had a scrutiny training of chairmans, and actually one of their thoughts was they wouldn't actually even entertain putting on for noting, for discussions. It would all be items for pre-decision scrutiny. And actually, my view is if you go down that road, you never have a thread of what's coming forward and input into other areas of the angle. So I think all in all, actually, as looking at our forward plan, they might get a bit busy because we only do meet every 6 weeks, but they really do get a good in-depth of the world of adults and what we are here to do, which is also scrutinise on pre-scrutiny decisions. So it is a balance, but things do move about without our control, which is why Simon interjects and actually comes in to update us. But, you know, I think all in all, we have quite a good balance. And you could say maybe some of us should actually stop talking so much and ask, or make some of the questions a bit simpler. But there we are. Right, item 10.
Karen just wanted.
Karen?
I wanted to just agree with Andrew. I'm so sorry I had to dash out. I meant to ask for a comfort break, and I just thought I'm going. Yeah. But and do you know what? I wouldn't mind doing extra meetings if there was something that really had. I'd rather talk something through thoroughly and come in extra than miss it.
Yeah.
Thank you.
Mark?
I think the Councillor Lee's made a very good point. If we do start to get a build-up on the work programme, just have an extra meeting to just to clear some of it.
Yeah. So. Right, skip on to number 10. Consideration of exempt information. Item 11 on the agenda contains exempt information, and we will now need to vote on whether to go into private session. I propose the following motion: that under section 100A(4) of the Local Government Act 1972, the public and press be excluded from the meeting for the following items of business on the grounds that it involves the likely disclosure of exempt information as defined in paragraph 3 of part 1 of schedule 12A of the Act. Do I have a seconder? Thank you. Andrew? All those in favour and again? Well, that's yes, all those in favour. That's everybody, so there's no need to worry about that. So I confirm that the motion to exclude the public and the